This conference will now be recorded.
Ma'am, can we restart?
– 15 seconds left.
Okay.
Yes, you can start.
I'm Dr. Menon, one of the candidate of part 3. I'm ready for a structured discussion.
Okay, so have you read the scenario?
Yes, ma'am.
So what are your differential diagnoses?
It would be the pulmonary embolism, okay, and some kind of some chest infections in pulmonary edema, and with abdominal discomfort, this OBP is abruption.
Any other differential diagnosis?
No.
All right. So what further information would you need from this patient?
Yes, I want to know her history regarding the how was the pregnancy just going on? Was IVF conception and any risk factors like antiphospholipids, her BMI, smoking status, and her um, is there any history of leaking right now, or any heart issue in this pregnancy, cardiac issue, and history of anemia? Is there any previous pregnancy, any other complication, mode of delivery, and VT risk factors?
Mm-hmm.
Regarding and examination is given, and I want to know the examination file, oh sorry, investigations uh, like her C, UC, and PTINR, and ECG, and ABGs, and ultrasound.
Anything
And
else?
now in the examination, BMI is, I want to know BMI.
BMI is 35.
And can you tell me all the investigations? Any which I mentioned?
Yes. These are her investigations.
Mm-hmm.
Can everyone see the screen?
Now we can see.
Yes.
Now I can see, ma'am.
Yes.
Yeah, okay. These are her investigations. How will you manage her?
I will counsel the patient and the family. I will admit the patient in the ICU, and I will involve the senior consultant, cardiologist, specialist in the nurse, and ICU manager, doctors, and pediatrician, maybe need of early delivery. And first of all, we manage the uh, so we continue. We also tell that risk for early preterm delivery, maybe need of cesarean section, and manage with. We will not give them overload the fluids, and
What is your diagnosis?
shows that it is cardiomegaly, peripartum cardiomegaly.
Mm-hmm. Okay.
Because left ventricular ejection fraction is 32 and peripartum cardiomegaly. So we will not give we restrict the fluids and involve the cardiologist management, and then we plan the delivery accordingly, and we also give the steroid cover,
Mm-hmm.
and also involve the anesthetist, and continue these managements.
Anything else? All right. So with acute management, she is improving. How will you further manage her?
Continue the treatment plans same, and we continue the follow up her. We plan and delivery with the all the team with the in the multidisciplinary team, and it is also remain high risk till 1 year for cardiopathy, and we will monitor her in postpartum period. We will continue VTA prophylaxis, discuss the contraceptions, and if she has the same symptoms, then she can report to the hospital and continue her management if need till 1 year, because there is remain risk till 1 year.
Mm-hmm.
Follow up for the next pregnancy and discuss the contraception for the next before um, and planning next pregnancy.
How will you optimize the postpartum care? Anything else you want to add?
One-to-one care, no overflows, pain management, and we can do instrumental delivery, no urge to push, and if cesarean needed, so consultant involvement and senior anesthetist involvement. Follow the WHO.
Okay. So if she comes with a future pregnancy, or she is planning for a future pregnancy, how will you optimize the management in subsequent pregnancy?
We get we start folic acid and echo and cardiac review to be to see what is the conditions, and then we go for, and if there are she's taking medication and not safe in the pregnancy, then medication can be switched, and start management in MTT team, consultant at delivery, and under the care of specialist care, the tertiary care.
Anything else? There's 1 more minute left. Anything you want to add?
No.
No. All right. No issues. Don't worry. Sometimes it's like that. You can expect new stations too.
Oh,
So
I didn't touch the cardiac issues.
yeah. So this is actually a station from the recent 2021 TOG issue 4 based on the peripartum cardiomyopathy. Okay. So it's in 2021. So possibilities are there. So coming to the key. Okay. So the way you started, Hera, I just want to tell you, whenever in a structured discussion, they ask you what are the differential diagnoses, always try to make it compact with a S bar. So start with a situation, background, assessment and history and recommendation, and then go on to your differential diagnosis. That's the way you start a station. So always, if you go with the S bar, there is a high chance that you will never miss the red flags which are there in the case. So there are certain particular red flags which can point to the case being coming from a cardiac case. Okay. So for example, are there any particular red flags that this is pointing to a cardiac case rather than an abruption? So one of the DD was abruption, right? So why did you say it's abruption? The uterus is relaxed. Why did you say abruption? Right? So
chest pain was warning sign, pulse was warning sign.
yes. So tachycardia was there, tachypnea is there, pedal edema with basal crepitations, and chest pain. So there are 4 red flags which pertain to a cardiac case, right? So that gives you an idea that this is probably a cardiac case. Now you have to think what are the cardiac causes at 32 weeks. So one of your differential diagnoses will be definitely pulmonary embolism. The other one will be peripartum cardiomyopathy. Then the rest of the things, infections, COVID, everything will come there. So that's the importance why you summarize it into an S bar format. So what are your differential diagnoses was the first question. See, you can comprehend, you can make it as a pregnant woman with acute breathlessness with suspicion of cardiac failure. Why cardiac failure? Pedal edema, tachycardia, tachypnea, and basal Krebs. So with acute breathlessness and suspicion of cardiac failure, background is a 35-year-old at 32 weeks gestation and G2P1. On assessment, she is having tachycardia, tachypnea, pedal edema, and basal Krebs. My recommendations for further management will be based on her history, further examination, and investigation, keeping the following DD in mind. So, what are your differential diagnoses? It could be an acute pulmonary embolism. It could be an acute exacerbation of asthma. It could be a peripartum cardiomyopathy. It could be an LRTA pneumonia. You need to rule out COVID. It could be a cardiac dysfunction secondary to ischemia, myocardial infarction, of course, is a DD. It could be a tachyarrhythmia. It could be a pre-existing valvular heart disease which got unmasked by pregnancy. And rare DDs like HIV cardiomyopathy and hypertensive heart disease due to pre-existing hypertension, any chronic hypertension due to due to an already existing heart disease. So these are the differential diagnoses for this case. Now, what information do you need means the information should include the history, information gathering, investigations, examination, and the investigations that you offer. So not just the history. And history, everything should come keeping all the DDs in mind. So information gathering, I'll quickly examine her and take detailed history regarding the symptoms of cardiac failure, the onset, duration, and progress of her symptoms, any dyspnea, orthopnea, PND, any pedal edema, what is the NIHA class, any unexplained cough, particularly when lying down, or any frothy pink sputum to rule out a pulmonary edema, Any dizziness, palpitation, fatigue, any chest pain, any pain radiating to arms and back, and the type of abdominal discomfort she is having. With respect to the present pregnancy, I would also like to know how her pregnancy is. Was there any complications so far? Any preeclampsia? Whether it's a multiple pregnancy, any bleeding PV, leaking per vaginum, any urinary symptoms, fever? How about her investigations? Anything abnormal was told to her? And how about the last scans? With respect to the obstetric history, I would like to know if there is any history of similar illness in previous pregnancies, her obstetric outcome in the previous pregnancy, when was the last childbirth, was there any postpartum complications? PPCM can manifest in the postpartum as well. Any postpartum complications? Any DVT? That all gets covered here. Medical history, anything relevant, especially any recent history of viral infections, because you know PPCM, one of the etiologies is a virus-induced myocarditis. So any recent viral infections, asthma, any history of asthma, any non-congenital or valvular heart disease, especially mitral stenosis, stenotic lesions or aortic stenosis, any history of hyperthyroidism or anemia, whether she is COVID vaccinated, any surgical history, allergy history, BMI. Why PPCM? Then I'll come to that. Blood group and reservations, her ethnicity, and history of DVT or pulmonary embolism, any family history of heart disease, ischemic or non-ischemic cardiac failure, respiratory infections in other family members, any addictions, her supports, and mental health as well. Examination presence of the chaperone, I would like to look for any pallor, any tachypnea, tachycardia, any peripheral edema, jugular venous distension, any murmurs, shifted apex beat, reduced air entry, rales, and hepatomegaly. Investigations, I would like to suggest the blood test, which include a hemoglobin, C-reactive protein, a WBC count, urine albumin, especially look for any preeclampsia. Since she is having the markers for cardiac disease, the natriuretic peptides, especially the BNP and the NT-proBNP, which are the markers of cardiac failure, the troponin T to rule out an MI, ABG if unstable. ECG to look for any tachyarrhythmias, any chamber enlargement and ischemic changes. Echocardiography, especially to look for any left ventricular hypertrophy, any segmental wall motion abnormality as an ischemia, ejection fraction, and whether there is any left ventricular dilatation. A chest X-ray to look for any pulmonary edema and any atrial or pulmonary trunk enlargement as in mitral stenosis. And if the chest X-ray is abnormal, she's having suspicious features, I would go for a CTPA as well. So these are your investigations. So what is your initial management plan? So you can see that the echo is showing ejection fraction less than 45%. So it's actually 32%. So the ejection fraction is less than 45% and the end diastolic diameter is more than 2.7 centimeters. So it's a peripartum cardiomyopathy with evidence of cardiac failure as per her symptoms and also with the chest X-ray. So this patient is unstable right now. So she requires a planned interdisciplinary patient-centered approach with optimal medical therapy and rarely augmentation of circulation and ventilation. So these are the three key principles which are mentioned in the talk. So it's a optimal medical therapy, mechanical augmentation of circulation and ventilation, and interdisciplinary, this multidisciplinary patient-centered approach. So the MDT approach would include a cardiologist, the obstetric physician, consultant obstetrician with an interest in maternal medicine or fetal or maternal medicine, an anesthetist, neonatologist, and an intensivist, and counseling. She should be admitted to the ICU and antenatal steroids, if between 24 to 35 plus 6 weeks, should be offered while transferring her to tertiary center. Now, so till now, so this is a case of peripartum cardiomyopathy. So peripartum cardiomyopathy usually is seen towards the end of pregnancy or within the first 4 to 6 months postpartum. So majority of them happen in this period, 78%, but around 13% can happen 1 month before the last month of delivery. So it can even happen at 32 weeks, right? Another 9% can happen at some point of time, which can happen even after 4 months after delivery as well. So the last month of pregnancy, it's mainly 9%, 78%, especially in the postpartum, and 13% can happen 1 month prior to the last month of pregnancy and 4 months after delivery. This is what the statistics show. So definitely, Danya, it can happen at that time. Now, so when you identify it as a peripartum cardiomyopathy, your management approach will depend upon whether the patient is stable, whether the patient is unstable. So an unstable patient can have features like she may be in a cardiogenic shock, or she may have features of cardiac failure, or she may have features of a tachyarrhythmia. So these are some of the features of instability in pregnancy. So how you manage a patient who is stable, how you manage a patient who is unstable, very very important. So as we said, an unstable patient, you will immediately admit her in the ICU. Now, in order to plan the further management, at least in short, as a gynecologist, you should know there are three classes of drugs. One is the vasodilator, one is the ionotrope, one is the diuretic, right? And the beta blockers in case there is a tachyarrhythmia. At least you should know these are the three classes of drugs that you give. Now, why you give these drugs in PPCM is also very, very important to know. In order to identify that, understand that, if you know the pathophysiology, you can clearly make it out why you give vasodilators. So in peripartum cardiomyopathy, what actually happens is, anyone who is interested to tell me about why peripartum cardiomyopathy happens? Anyone can volunteer. Anyone?
Dr. Vrinda, increased load during the pregnancy on the heart.
Yes. Yes. Initially it was thought that it could be a virus-induced myocarditis. But later, when they did some cardiac MRI, they found that there was no evidence of myocarditis. So then came the theory that it could be the stress of pregnancy. Yeah, the circulatory load, overload that happens in pregnancy could produce a strain on the heart, and that can predispose to PPCM. But when does this strain happen actually? The raised cardiac output and the plasma volume increase, everything happens by the early second trimester. But peripartum cardiomyopathy is usually seen towards the end of pregnancy, right? Towards the third trimester. So that was also not correlating. Then came the theory like the two-hit theory, where they predisposed that there are certain transcription factors which are normally increased in pregnancy, but those women who have a genetic predisposition to develop PPCM, these transcription factors are not produced as expected, and there is an increase in bromocriptine levels. These reduced transcription factors can stimulate reactive oxygen species, which produce a protein called cathepsin D, which will break down the increased prolactin to 16 kDa prolactin fragment. And this 16 kDa prolactin fragment is the one which produces cardiac myocyte injury. And this cardiac myocyte injury is the one that predisposes to peripartum cardiomyopathy, that is during the late pregnancy. Now, why should it happen after delivery? They say that there are certain proteins like just for you to hear and leave, so that you remember the pathophysiology, you remember what drugs to be given. So there is an increase in certain soluble FMS like tyrokinase, which are produced by the placenta in every normal woman, which will reduce the amount of postpartum hemorrhage. And this SFLT1 will prevent PPH in every woman. This is produced by the placenta. So once the delivery happens, placenta is removed, what happens? The SFLT1 level should come down. But those women, again, who have a genetic predisposition, the SFLT levels will not come down, and they will inhibit the vascular growth factors, and this will inhibit the this will cause damage to the endothelium. And this will cause peripartum cardiomyopathy in the postpartum period. That's why in the antenatal period, why it happens, postpartum period, why it happens. That's a basic theory behind that. Just leave all those theories just for you to know. Now, what happens in peripartum cardiomyopathy? The left ventricle gets dilated. So the left ventricle gets dilated, and the end diastolic diameter goes on increasing. So the cardiac output decreases, right? So once the cardiac output decreases, the renal perfusion gets affected. Whenever the renal perfusion is affected, it will stimulate the renin release. So when renin is released, the old physiology, renin will convert angiotensinogen to angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by the ACE enzyme, right? So there is a lot of angiotensin 2 which can cause fluid and water retention. Aldosterone concentration is increased, and this can also cause arterial vasoconstriction. So three effects: fluid retention, aldosterone levels are increased, and arterial vasoconstriction. So what do you give in order to, so arterial vasoconstriction will cause, finally the preload will be affected, and there will be pulmonary congestion. So pulmonary edema happens there. Now what will you do to reduce the arterial vasoconstriction? You give vasodilators. What do you give for fluid retention? You give diuretics. What do you give for tachyarrhythmia? You give beta blockers. So these are the three main classes of drugs that you give in PPCM. So just remember these three drugs and why you give these three drugs. So after admission for this patient, what do? You will start her to optimize the preload. So how can you optimize the preload? By giving diuretics. So you give intravenous diuretics, and the vasodilators which you give are basically the nitrates, right? So you cannot give ACE inhibitors. So ACE is the reason, so but you cannot give ACE inhibitors in pregnancy. You cannot give aldosterone antagonist. You cannot give mineralocorticoid antagonist like the spironolactone in pregnancy. You cannot give ARBs in pregnancy. So what type of vasodilators can you give? You can give hydralazine. You can give nitrates. So these two can be started, especially if the BP is more than 110. Then what else you can offer? You have to maintain the oxygenation. The perfusion has to be maintained to maintain at least saturation more than 95%. And you keep the patient in a semi-recumbent or upright. The thorax should be kept upright posture. And in order to facilitate, if the saturation is falling, you have to put her on NIV with CPAP support, and this can decrease the intubation rate. But however, if the saturation is not improving, intubation and ventilation has to be considered. Any arrhythmia, you will start her on beta blockers, especially the metoprolol, which is selective beta-1 antagonist. Now, what do you offer for the circulatory support? She's going in for hypotension. She's going in for cardiogenic shock. You will have to offer her inotropes and vasopressors. But in especially the adrenaline and dobutamine are less favorable here in cardiogenic shock because they increase the myocardial oxygen demand and the work strain increases. So the preferable one is the noradrenaline. Or the recent trials show you can consider a drug called levosimendan, which is 0.1 Lg per kg per minute and for 24 hours instead of the catecholamines. So just remember the name levosimendan. And you see that there is an increase in bromocriptine. So you can give, prolactin. So you can give bromocriptine. So 2.5 mg OD for 1 week if uncomplicated, and 2.5 mg BD for 2 weeks, followed by OD for 6 weeks, especially if the ejection fraction is further deteriorating and there is presence of cardiogenic shock. Along with that, you have to start anticoagulants, especially with bromocriptine. Bromocriptine, there's a high chance of intracardiac thrombus. You have to even otherwise, when the ejection fraction is reduced, there is high chance of DVT and pulmonary embolism especially. So you have to anticoagulate her. And if the patient is persistently unstable despite your management, you have to consider a decision for urgent delivery and in accordance with the multidisciplinary team. So patient not improving, you have to go for urgent delivery. Now, if the inotropic support fails, she may have to be put on intubation and ventilation. Temporary ventricular support devices like the balloon pumps, and just remember the name assist devices, ventricular assist devices may be required if this is further worsening. And the last option, if the pulmonary dysfunction is persisting, ECMO is the option. So at least remember, so she should be, the preload should be optimized, oxygenation should be maintained, an IV and CPAP to maintain her oxygen with the ventilation, beta blockers for arrhythmia, and inotropes and vasopressors depending upon whether she is proceeding to cardiogenic shock, and the newer drug, the levosimendan, bromocriptine, and anticoagulation. Unstable patient, a decision for urgent delivery. Cesarean section, especially if the ejection fraction is further decreasing and patient is not improving, or patient is unstable, or she is having she is in cardiogenic shock or irreversible tachyarrhythmia, you have to consider cesarean section. Now, the fourth question was, with acute management, she improves. So how will you further manage her? So if you look at the talk, it definitely divides it into how you care the pregnancy in a stable woman, how you care the pregnancy in an unstable woman, what will you do in the postpartum if she's breastfeeding, what will you do in the postpartum if she is not breastfeeding. So this is, she is improving with your care. So how are you going to manage her? So once she improves, she can continue. So she is improving, her ejection fraction has improved. You can have a detailed care plan, MDT follow-up and consultant-led unit care, serial fetal growth scans, more frequent visits, and consider delivery at term by 37 weeks, and vaginal delivery is preferred if stable. Continuous CTG. So intrapartum monitoring, how will you do? So continuous CTG, 30-degree left lateral tilt she should be monitored. There should be an intrapartum care plan. Hourly monitoring of fluid balance with a 4-hourly assessment by a senior clinician. Blood pressure, pulse rate, and oxygen saturation monitoring is recommended. Continuous ECG, pulse oximetry, and assessing the cardiac output with non-invasive techniques. Low dose regional analgesia, and cut short the second stage. Active management of third stage with low infusion oxytocin, very, very important. Otherwise, there could be sudden hemodynamic compromise. Misoprostol and carboprose can be considered as second-line agents, but you have to avoid long-acting oxytocin analogs like the carboprost and ergometrin because it can cause hypertension and secondary cardiac failure. Postpartum, how will you manage her? So if she's hemodynamically stable, she can breastfeed. But if ejection fraction less than 45% with hemodynamically unstable and symptomatic patient, the recommendation is to deter breastfeeding. And in the postpartum, you can definitely, if you need to continue the vasodilators, you can switch on to ACE inhibitors or ARBs, or you can continue the angiotensin or aldosterone antagonists, but carvedilol and the mineralocorticoid antagonist spironolactone is not recommended in postpartum. Low molecular weight heparins have to be continued for minimum 6 to 8 months until she recovers. Beta blockers, AC inhibitors, and ARBs till ventricular function normal. Sometimes it may take up to 12 months postpartum. Vasodilators and diuretics, you can discontinue when they are asymptomatic. When do you offer echo? Echo has to be offered prior to discharge, prior to discharging the patient, again at 6 weeks and at 12 months, or if there is any worsening. And she should have a continued follow-up with the MTT. With respect to contraception, the best would be IUCD. But when you insert an IUCD, there is a high possibility that vasovagal shock can collapse, so which can induce an arrhythmia as well. So insertion should only be in the hospital setting. Combined hormonal contraceptives should be avoided because of the presence of estrogen increasing the risk of VTE, and LARC is also preferable. When considering permanent methods, the risk of anesthesia should be kept in mind. Also, team debriefing has to be done before discharging the patient and counseling her regarding the future pregnancy. What will you counsel? 50 to 80% of the women recovers, even though the mortality rate is still there, which is around 10%, but it has come down from the initial 50% to 10%. With respect to the future pregnancy, if she is having a persistent left ventricular dysfunction, 50% chance that this may further deteriorate in the subsequent pregnancy. So she has to be followed up with an echo, and preconceptionally also she should have an echo. So if there is a persistent ventricular dysfunction, 50% chance that if she considers a future pregnancy, she may deteriorate, and the risk of mortality is increased from 10 to 20%. And if she's completely recovering and her left ventricular function is improving, still there is a 20% chance of relapse in the future pregnancy. This should be counseled to her. And when is pregnancy contraindicated? If her initial ejection fraction was less than 25% or it is not normalized after the treatment, then a pregnancy can be avoided. This is a suggestion. How will you manage a subsequent pregnancy? For example, she has recovered, ejection fraction has improved, so she's planning for a subsequent pregnancy. What advice will you give? So she should have a preconceptional counseling with the same multidisciplinary team, and it should be ideally in a tertiary care setting. The medication should be reviewed, whether she is continuing these medications. So they have to be altered to a safer one. Preconceptional echo has to be done, and what are the indications for avoiding a pregnancy has to be considered. Once pregnant, early booking and consultant-led care. Frequent antenatal visits should be offered. Close follow-up in pregnancy. Echo has to be repeated at the end of each trimester and 1 month before delivery. Continue the beta blockers, and she should be closely followed up with echo and BNP levels. So BNP is a marker for cardiac failure, right? So you follow up her with regular BNP levels. Women with peripartum cardiomyopathy, especially if they are with LV dysfunction, they have to be offered anticoagulants. And serial scans has to be offered for fetal growth from 24 weeks of gestation, and timing of delivery will be dependent on her obstetric indications, if any, and like an FGR or preeclampsia. So the risk factors, as you know, PPCM, the risk factors are multiple pregnancy, obesity, age more than 30 years, or a previous history of peripartum cardiomyopathy, or those with chronic hypertension or preeclampsia. Especially those with preeclampsia associated PPCM, they have a good prognosis. So what is the indication? So it will depend upon the indication, whether any FGR or preeclampsia, depends upon the vaginal considering the induction of labor or delivery, or if there is any worsening cardiac function. So subsequent pregnancy, the target would be at least to reach 37 weeks of gestation. So vaginal birth is recommended unless there is a need for cesarean section for obstetric indications or because of any cardiovascular compromise. And postpartum anticoagulation is recommended for 6 weeks. So that's all about peripartum cardiomyopathy. Any questions? Just when I went through the talk, I saw this case. So yeah.
Excuse me, can you show the after information gathering, the slide after that? Next slide, please.
This one?
Next slide after that. The next one. Yeah, thank you.
Any doubts? So you can see that these investigations, you can see PPCM, they say the hemoglobin will be slightly reduced. CRP levels are elevated. Total count may be elevated. NT-proBNP, it's more than 1220. The normal should be less than 300. So this is also elevated. The urine albumin is 1+. There is an associated preeclampsia here. Coming to the echo, ECG, you can see there is a tachycardia. Ejection fraction is reduced, end-diastolic diameter is increased, and chest X-ray is showing cardiomegaly and pulmonary edema, evidence of failure. So all these things are represented in the investigation. Any questions? Hyra? Hyra? Are you there?
Yes, ma'am.
Any questions?
No, thank you.
Please don't worry. See, this is just to give an importance to the recent talks. So this came in 2021. So please go through the recent talks. So this is just to create an awareness regarding the importance of the recent talks. Okay. Yeah.
Thank you.
Any questions, anyone? Any questions?
Dr. Vrinda, I have one question. If in the
Yes.
case, if all the investigation was given before, so should we need to say again that I need to investigate all these reports? Already they are given.
I didn't show you the investigation, right? See, you are going for a face-to-face examination. I asked you first, my first question was, what are the differential diagnoses? Then I asked you, what further information would you need? Once you say the investigations, I'll show you the investigation results.
Okay.
That was the way I went. Yeah. Any other questions? See, when you're going for a face-to-face exam, this slide may not be there. So please listen to them very, very carefully. The questions may be asked, so you won't be able to see. So once it was an online exam, in the slide, you would be able to know. So what is the next question? So how you can plan, you will be having an awareness. But once you're going for the face-to-face examination, this slide won't be there. So the questions will be coming as a rapid fire. So keenly listen to these questions. If you have no doubts, we'll move on to the next station. Okay?
Dr. Vrinda, Regarding
Yes.
the new talks, it's really very less time remaining to cover up the new talks. We have no idea that which new talks are launched. So, is there any new talk in these recent months that needs our attention besides this one that you have discussed, or like any new talk which has not already been covered in any nice guidelines or GTG, so that at least we can pick up those and start giving a rating for that?
See, the way you go through the talk is usually the question papers are set 6 months before. So that was the way we used to prepare those talks that happened before our exam, 6 months prior to our exam. Till that, we used to go through.
Okay.
So you have to see to those the way. I'm not an examiner. I have no connections with the RCOG. What I used to do was that those stations indirectly related to pregnancy, I used to go through. For example, like an adrenal disease in pregnancy, if I am going to give the exam, I won't give much importance to that. Rather, I'll give importance to a peripartum cardiomyopathy if that is there, because that is something which we see more. So that's the way I used to give importance. So like that, you have to search over the talks. I can only tell you that, right? Nearing the exams. So I can't say you go and read this, you go and read this, that I cannot say.
Yes, yes.
So those
That's what
related
I
to,
wanted.
yeah, those which are more related to you in practice, those which are associated with your GTG and NICE, please go through them.
All right. But everybody says that GTG is the main thing that we have to read, and mostly it is followed. So if GTG and
Anything
talk,
can come.
yeah,
See,
from the same topic, we should all prefer the GTG rather than talk.
yeah, I always went with the notion that anything can come,
Yeah.
right? And if you expect the worst, you get the best. That's the best thing. So just go
Yes.
through. So if you can just, it takes hardly 15 to 20 minutes to go through a talk, because they have everything in the boxes. You need, so how many days you need? So at least one day you need one talk, one article in a talk. So you have for the 10, 20 days, right? So one article per talk in the last 1 year or 1.5 years, just go through them. The rest, everything you have read for your part two, right? So you know something here and there. Okay.
Vrinda, thank you.
Right. So the next case, any volunteers for the next case?
Can I give a try? Although I am not sure what kind of case is going to
Menon.
come.
Yeah.
Yes.
All right. Yeah. Can you see?
Yes, case two.
It's an AC station. Your time starts now.
Okay. Can I start?
Yes, you can start.
Hello, I'm Dr. Humaira, one of the doctors in the antenatal clinic today. May I confirm your name and age, please?
Jeremiah, 35.
How may I call you?
Jeremiah.
Jeremy, I can see that currently you are 36 weeks pregnant, and this is your first pregnancy, right?
Yes.
And you're requesting for home birth.
Yes.
So, any other concerns and expectations from today's appointment?
Oh, well, I already got a big lecture from my midwife that I should have a hospital delivery and blah blah. I'm not interested in all those stuff, okay? I just want to have a delivery at my home. That's all.
Okay. I've gone through your case notes. So, Jeremy, will that be fine if I ask you a few questions just quickly to know more about you so that I'll be able to discuss a plan for your delivery which will be more suitable to you? How does it sound?
Oh, yeah.
If you can just have a chit chat over just to know few more things, right?
Yes.
So, Jeremy, can you please tell me more about your concerns and about yourself, about this pregnancy?
Oh, well, me and James, we are waiting for this baby for a long, and one of my friends, she had a very difficult experience when she came to the hospital. She was put on all those injections and a lot of those plastic cannulas and all those rubbish things. And finally, after 18 hours of suffering, she was taken for a cesarean. I just don't want all those things to happen, right?
Yeah,
Yeah.
I can see your friend must have been through a difficult time. That really puts you in a stress that similar thing might happen to you. But Jeremy, let me assure you that every person is different. Every individual has their own circumstances and their own uh, all own problems. Like their body could respond differently to some different things. So if your friend has something, it's not necessary that you would be having the same thing, because you see. Whatever we will discuss, it will be for your own safety and for your baby's safety. That is our utmost priority. So whatever we are going to discuss, that will go in your favor, right? We are not pushing you towards anything or not forcing you anything, but it's just a cross talk that we can come to a mutually agreed plan, right?
That's good.
So how is this pregnancy going so far?
So far, so good.
Have you named the baby?
Yeah, Sarah.
Good, nice name. And is Sarah kicking well?
Yeah.
Good. So at the moment, any problems like any pain, bleeding, leaking? Nothing? Good. And your recent ultrasound scan is done?
Yes.
Right. So, and uh, uh, do you have any other medical problems like diabetes, high blood pressure, clots in the legs and lungs?
Diabetes, no. Clots, no. What did you ask? Then what did you ask?
And clots in the legs and lungs?
No.
High blood pressure? Nothing. Okay, good.
No.
Any such illnesses running in your family?
No.
And are you allergic to anything?
No.
Okay, so any surgeries in the past on your tummy or down below?
No.
May I know, do you smoke?
Sorry?
May I know, do you smoke?
No.
Take alcohol?
No.
And pardon me to ask, any recreational drugs?
No.
I appreciate that, Jeremy. All right, so what do you do for a living?
I'm a housewife.
Do you feel you're well supported at home?
Yes.
That's really good to know. And did you feel low or depressed in the past few weeks?
No.
And less interested in day-to-day activities?
No.
So may I know your blood group?
A positive.
Okay, do you have any reservations for blood transfusion in case the need arises in future?
No.
Thank you so much for sharing this information, Jeremy. Is that anything you would like to add?
No.
So coming to your concern about your plan of home birth, right? Jeremy, I can see from your ultrasound findings that there is a fibroid in your womb, right? It's a 6 centimeter size fibroid. It's quite a big fibroid. So I'll be discussing with you about how it can affect your pregnancy and delivery. So I appreciate that you you're thinking for home birth. Home birth is a good choice, but for those women like who are low risk, having low risk pregnancy, who are not having any problems, and you're surrounded by your partner, your your relatives, your friends. You don't have the buzz of and hustle and bustle of the hospital. You're not like supervised by so many people. You're at the peace of your home. But that is a good option for those who don't have any such problems. But I'm afraid, Jeremy, that there are certain concerning things that I would suggest that home birth won't be a suitable option for you, because I told you that your safety and your baby safety is the utmost priority that we are looking for.
Mm-hmm.
In your case, because there could be some risk factors associated with the fibroids that you have, it could cause like prolonged labor. It could cause baby might be in a different position, not head down at the time of delivery, or it could cause delay in the labor, and also there is a risk of heavy bleeding after the birth of the baby. So for these reasons, we need to monitor you. Also, I can see. Just a moment. Also, I can see that the weight to height ratio is a bit on the higher side. Jeremy, that also puts you at a risk of like having some problems during the delivery, having a prolonged labor, or baby might get stuck, and there could be risk of heavy bleeding. The option of giving you to deliver in the consultant-led unit and hospital is we need to monitor your baby for the heartbeat continuously, and also we need to see if your labor is going on progressing on fine. So because we need to put monitors on your tummy, and that won't be, I'm afraid, that won't be possible. That won't be possible. Just a moment. Just a moment.
Yeah, I have paused you.
For the disturbance. So, Jeremy, because of these risks, your monitoring will be in the hospital, one-to-one monitoring in the consultant-led unit. And if any complications arise, we would have to definitely intervene. Being in the hospital doesn't always mean that there would be a complication, as you said, that your friend had all this. So being in the hospital means that your care will be more closely monitored. So if anything happens that is going like not in favor of your safety, that we have to take care into consideration immediately. And regarding, because you have to monitor you and your baby as well, we have to take care of any risk of clots developing in the legs and lungs immediately. Risk of clots developing in your legs and lungs. So we have to be careful whether giving you stockings or need to give you blood thinners as well. Am I clear?
Yeah.
So because the labor can be prolonged, there could be some problems with the baby's heartbeat, baby's well-being. We might need to do a cesarean section immediately in case if anything happens, if your labor is not progressing, or baby's heartbeat is not well. So for these reasons, we recommend that it's safe for you to deliver in the hospital in a consultant-led unit. Am I making sense?
Yes.
Do you have anything to ask? Any confusions or anything that I have not made clear?
I don't want any injections.
Okay, so we respect all your wishes, whatever you wish, but injections, we maximum take care not to give you injections. But in sometimes, like when the baby is delivered, there could be risk of bleeding. Then just to save you from heavy bleeding, we might need to give you injections. Rest, we take care that we might not need that injection, but in case if injection is needed, then we have to give you these injections. And in the hospital, we bypass you the cannulas, and fluids will be going. Pain relief, especially if you would opt for any pain relief like epidural. I'm afraid it won't be possible at home, and it's only possible in the consultant-led unit.
No, I know you are telling all these things just to prompt me to come to hospital. No, I am not interested. I won't come there.
Okay. these are the things that are really important to discuss with you, because owing to the risks of having the fibroid, and this is your first pregnancy, so they could be risking prolonged labor, and like labor might not be up as quick as it should be. So we might need to do some intervention. So if still uh, you have still some time, I'll give you information leaflets. In the meanwhile, I'll inform my consultant about this. So if you have any doubts, you can talk to my consultant.
On time.
Okay.
Excellent. Very well done, Humaira.
But I'm sorry, because of these unnecessary kind of phone calls, and really, I couldn't pay so much attention.
That's acceptable, but you completed on time. All right. So this is the right approach to any negotiation station where the patient wants to have a home delivery, right? So the very right approach, I would say, because she did not always try to convince me, but just one point I want to tell you, Humaira. At the
Yes.
end, the role player keeps on saying, no, no, I don't want. Please
Yes,
don't
put her
try
with
to
the consultant.
be judgmental. You can just leave saying, I'm sorry, in spite of all efforts, I failed to convince you, but you don't have to take a decision right now. I'll provide you the leaflets. Please have a look on that. You can go home, discuss with your partner. I'll also fix an appointment with the consultant. You can come back and rethink again. There's no hurry. You can take a decision later as well, because it's only 36 weeks, and leave. Okay, don't try to say no, 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 it can cause bleeding, no, no, it can cause tear, no, no, you have to come to hospital. No, don't impose. Her wishes should
Okay.
also be respected, right? Okay, so that's the only thing I want to say. The other points I have noted would include, not much relevant, because all these things, minor things, will get covered by the way you counsel me. So one is, you can ask me how far I stay from the hospital, right? So I want to have a home delivery, so something happens, some complications happen, so how far I stay from the hospital? Is there any ambulance facility, any transport facility to bring me to the hospital? Is there somebody at home to take care of me if there is an emergency? Okay, that is important. Second
Yeah.
is, you're seeing for the first time probably, she's at 36 weeks. Offer an examination, right? So you want to know if the fetal heart rate is still there, right? So offer an examination, check her blood pressures. I would like to examine you in presence of a chaperone with your consent, just to look at your blood pressures and the tummy. Is it okay with you? So just offer an examination. These are the two things I have not addressed everything you have said. Okay. So coming to such a station, in every negotiation station, very, very important that your tone should be low. Keep the notion in mind that at any point this patient can become aggressive, so your tone should be very, very mild, and it should be very, very sensitive. So the way, as she said, hello, I'm Dr. Vrinda, one of the doctors in the clinic today. May I confirm your name and age, please? I'm given to understand that you are having some concerns regarding your birth plan, am I right? Any other concerns would you like to share with me? And then give your agenda. So Jeremiah, is it okay, can I ask you a couple of questions to know more about you? And then we will discuss with you regarding all the management options, and at the end, whatever you decide will support you and will respect your wishes. So once you say this, majority of those aggravating ladies, they will come down. So whatever you decide at the end will support you and will be respecting your wishes too. Then ask her, so Jeremiah, can you tell me, may I know the reason behind why you prefer to have a hospital delivery? Don't just go and ask her, why do you wish to have a hospital delivery? No. So the tone is different. That shows you are judgmental. Just ask, may I know the reason behind why you prefer to have a home delivery? Then you start appreciating her. So if she has some concerns, whether she had a previous delivery which ended up in cesarean section, you go with that. So as the way you rightly said, the circumstances may differ, risk factors may differ, every woman is different, your situation may be different from her situation, or your previous situation may be different here, but I'm not quite sure about what happened. If it's a previous delivery that she had a difficult situation, you can just ask, I would like to review your notes just to see what happened last time, and then tell something good about the home delivery. So I really appreciate that home delivery has its own advantages. You are in your home, you have everyone that you know around you, you are in full control. Yes, these are all the good things, but definitely it has some disadvantages too. In order to identify if there are any risk factors associated with home delivery, because our ultimate aim is your safety and your baby's safety. The right way you said. Is it okay? I can ask you a few questions. Then go to your complete information gathering. Once you do the information gathering, you come back to the examination. Then how do you take this patient? So this patient has got two risk factors. One is the fibroid, one is her class 2 obesity, BMI 37. So after offering the examination, you come back, you tell her, so Jeremiah, from your history, I can see that there are two risk factors. One is the fibroid and the other is the weight height ratio, slightly to the higher side. So with these risk factors, the home delivery may not be suitable for you because of certain reasons, right? Then what you can say then? Home delivery is of course a good option for low risk women. But even in a low risk women, there's a 50-50 chance that they maybe have to shift it to hospital. Even there is a chance that during delivery, in 9 in 1000, the baby can be born stillborn. I don't mean to scare you, but it's my duty to give you the right information. And in your case, you have every right to choose when and where to deliver. But with me as a doctor, it's my duty to give you all the information regarding why we recommend to have a hospital delivery and why we recommend not to have a home delivery. At the end, once you have all the information available with you, you can decide and we will again support you. So something like this, you will have to say all through. So that is the importance of negotiation, right? You will have to keep on talking, a little bit more you will have to talk rather than going straightly to the risk factors. Now, with respect to the fibroid, there is a possibility that the labor can be prolonged. There is a possibility that you may require an increased chance of cesarean section. There is a possibility of increased bleeding after delivery. With respect to the weight height ratio to the higher side, again, there is an increased risk of slow and prolonged labor. There may be difficulty in monitoring the baby's heartbeat. Sometimes there is an increased chance of having a cesarean section. There is also an increased chance that once the baby's head is delivered, the shoulders can get stuck and additional maneuvers may be required to deliver the baby. And during this time, there are possibilities. There could be an excessive bleeding. There could be tears in the back passage, which may have to be repaired in the theater in presence of an anesthetist by a senior doctor. Sometimes the baby could be unhappy in between that we may have to take for an emergency cesarean. All these things will be delayed if you're considering a home delivery. That is why we are recommending a hospital delivery. In a hospital, now what you can do to prevent all this? In a hospital, we can offer you an early plastic cannula so that we can keep you well hydrated so that your labor doesn't go prolonged. We can offer you an early epidural so that you can remain calm and composed during labor. We can offer you a one-to-one care. We can offer a small belt which can be tied along the tummy so that the baby's heartbeat can be continuously monitored. And we can offer you medications if the labor gets prolonged in order to augment labor, and also medications to reduce bleeding. Following the delivery, there is an increased chance of developing blood clots, for which we can give you additional medications and the lovely white stockings so that this will prevent blood clots. So these are the reasons why we recommend a hospital delivery. What are your thoughts about it? Just ask, what are your thoughts about it? Then she will tell you what is her thought, whether, yeah, I think I should consider this. Okay, she's coming in your way. Still, she's aggressive. No, I'm not agreeing to your decision. I just want a home delivery. Both of it doesn't mean that you are failing the station. It is only because the role player is instructed to act so. So if you perform this way, you will surely pass. So whether she gives way, whether she doesn't give way, it doesn't matter. At the end, even if she's not giving way, you just say, I'm sorry, despite all the efforts, I failed to convince you. But as I said, you don't have to take a decision right now. I'll fix an appointment with the consultant. Meanwhile, you can go home. Just have a look on the leaflets. Any doubts you can write behind it, bring back. You can also discuss with the partner. We can also discuss with your partner as well. And there is ample time ahead. And the next appointment will be the consultant. I'll also document all this in the case notes, and I'll provide you the contact numbers in case 24/7 numbers in case you have any need. You can definitely contact us. And say thanks. Thank you for your time and leave the station. Now, if she says, as I said, I don't want any injection, what you can say? The way you said, yes, we won't give any injections unnecessarily. The only time we give or we interfere when the labor gets prolonged or if there is an excessive bleeding to save you. And at that time, we will be taking every measure to avoid injections. And if you do not wish to have any injection, we can document that. You can also have an advance directive if you wish. So that's the way uh, you can give your idea there. All right. So this is how you take up a negotiation station. Any questions?
Yes, Dr. Vrinda, very nicely explained. Thank you.
Right. Any questions, anyone?
Ma'am, I wanted to ask, what if she's telling that about the I don't want injection? So how we have to tell her we would give it for like the active management, or we would that how do we say?
Yeah, that's what I said. We don't give any injections unnecessarily. The only time we do interfere are once the labor gets prolonged, we may add injection medications, and if there is an excessive bleeding to save your life. But if you do not prefer to have any injections, we can definitely document that. Everyone who takes care of you will be reading that and they will be aware of this. You can also keep an advance directive if you wish. That's the way you take up.
Okay, ma'am.
You cannot impose any injection on anyone. Can you give blood transfusion if she is having an advance directive? Oh, she's a Jehovah.
No,
How
no,
do you
no,
do
ma'am.
that?
I was not talking about the blood, but just for the like the management, active management when she would deliver at that time.
Yeah, this is the way you can say. You can also
Okay.
say there are medications which can be kept below the tongue or which can be kept in the back passage, which can reduce the bleeding. If you do not wish to have the injections, then we can document that and that can also be used. The misoprostol.
Okay.
Dr. Vrinda, what would be the answer for the water birth for those patients who are VBAC and this patient for the water birth?
Those patients who are for VBAC, you can say that, hello?
Yes,
Yeah.
yes.
So in case of VBAC, you can say that the baby's heartbeat needs to be continuously monitored. And in water, sometimes it may be difficult. Underwater, it may be sometimes difficult. So we will also inquire if telemetry is available. And if telemetry is available, we'll definitely let you know. Otherwise, if telemetry is available, we'll be able to know if there is any abnormality in the baby's heartbeat, then we'll immediately ask you to come out of the water birth. This lady, she can have. Definitely she can.
Means they both can have, but we will see the telemetry.
Yes, we'll see if telemetry is
Okay.
available. But you have to tell her, VBAC, there is a high chance that the scar can give way. But you need the consultant's opinion as well. Don't take any decision by yourself. We'll inquire if telemetry is available. I'll also have a word with my consultant.
Okay. Okay. Thank you.
Any other questions? Shall we go to the next station? Any volunteers for the next station?
Can I go?
Who's this?
Salma.
Salma, yes. Salma, can you see the screen?
No. Yes,
Now,
case 3. Yeah.
your time starts now. can start.
Hello, I'm Dr. Salma, one of the doctor in the postnatal ward today. May I check your name, please?
Gemma Splits, 25.
What would you like me to call you?
Gemma.
Gemma, I can see that you had cesarean section. And how is your recovery? Any pain or bleeding?
Yeah, well, I had a cesarean yesterday, doctor, and it's painful too.
Congratulations. How is your baby?
Yeah, my baby is in the ICU. I haven't seen my baby.
I'm sorry to hear that. What happened?
Well, the the doctor said that the baby is preterm and baby needs an ICU care.
Mm-hmm. Did you see your baby till now?
Oh no.
Mm-hmm. I'll contact with the pediatrician and I'll talk to them. Yeah, then I'll come back to you about your baby condition. I'll update
Mhm.
it. Okay.
Thank you.
Mm-hmm. So, can you tell me that after delivery, did you pass urine and any problem with your bowel
No, I just emptied my bladders.
and open your bowel?
Not it.
Mm-hmm. Any pain in your tummy?
Yes, the cesarean pain.
Mm-hmm. Have you taken pain relief?
Yeah, the nurse just gave me.
Mm-hmm. So, are you comfortable to talk with me now?
Yes.
Mm-hmm. So, can you tell me more about your cesarean section? Any problem during cesarean section?
Oh, well, doctor, I'm unfortunate that I had cancer of my right breast,
Mm-hmm.
and this was detected at 24 weeks, and the doctor said that the surgery has to be done.
Mm-hmm.
And the surgery was done, and the cesarean was done at 28 weeks.
Mm-hmm. So, why cesarean section done in 28 weeks? Any
Uh,
problem?
yeah, they said I need some treatment again.
Mm-hmm. So, are you taking any medication now?
No.
Mm-hmm. So, can you tell me more about your breast cancer?
This was actually detected during pregnancy. I was not aware of anything. I was having a feel of a lump in my right breast, and when I came for my routine checkup, I was offered a biopsy, and that showed it's a cancer breast.
I'm sorry to hear that. How you're coping with this?
Okay, the surgery was difficult, doctor, but now I'm slowly coping up with.
Mm-hmm. Gima, you are not alone here. We are with you. Okay, so you need more support. Yeah, so I'll give you the support group contact details, and also our Macmillan nurse. She'll give you all support, every step what you want. Okay,
Thank
Gima?
you, doctor. Yeah.
Yeah, yes. So, can you tell me that have you taken any medication before that for the breast cancer?
No.
Anything? Only the surgery done. Yeah, yeah. The lump is removed.
Yes.
Yeah. So, any family history of the breast cancer or ovarian cancer?
No.
Hmm. Have you taken any contraception before?
No.
Hmm. And do you have any other medical disease that you are following to GP?
No.
Hmm. And do you have any problem during your period, any heavy period or anything?
No.
Is it regular?
Yes.
Hmm. And how many children you have before?
This is my first pregnancy, doctor.
Hmm. And do you have enough support at home?
Yes, my husband is very supportive.
Hmm. Do you smoke?
No.
I appreciate that. Drink alcohol?
No.
Hmm. Are you taking any medication now?
No.
Hmm. Any allergy to anything?
No.
Do you know your BMI?
28.
What do you do for your living?
I'm a housewife.
Mm-hmm. Thank you for sharing all information. Do you want to add anything?
No.
Mhm. Now, in front of chaperone, with your consent, I'll check your tummy. There is any pain, or I'll check down below. There is any bleeding, and also I'll check your breast. Also, there is any problem. Yeah, and okay. So now coming to your that you want for the discuss with the contraception advice. Yeah, am I right?
Yes.
Do you have any other concern that you want to share?
No, I just want to know if I can have some contraceptives because I would like to delay a second pregnancy.
Sorry, delay second pregnancy.
Yeah, I would like to know
Yeah.
if I can have some
Okay.
contraceptives.
Yes. Yes. As you have that breast cancer, okay, and your BMI also, it is high. Yeah, 28. So
Mm-hmm.
that means the suitable contraception will be copper coil. Yeah,
Mm-hmm.
and hormonal contraception is not suitable for you because of breast cancer.
Mm-hmm.
Yeah, am I right?
Yes.
Yeah. So, and this coil, there is it is 99% effective, and there could be, the bleeding, and sometimes there is a heavy bleeding. So even though there could be pain, yeah, so we'll give you medication at the time, and there it could be expel out also. 20% case it could be expel out, and you need to check the thread. Yeah, if there is a no period, then you have to will do for pregnancy test, because there is a risk of uh, uh, pregnancy outside the womb. Am I clear?
Hmm.
Yeah. So but the risk of sexually transmitted infection, it will not prevent. So that's why you have to do the safe sex, to use the condom. Am I clear? Do you have any
Yes.
question? Do you have any
Uh,
question?
yeah, doctor, I have heard that one of my friend who also had a cancer breast, she was actually breastfeeding from the other side, and well, she did not use any contraceptives, and the baby will, and she did not use any other methods, and she was protected from a pregnancy. Can I have that?
Sorry, what you want? Can you?
Yeah, well, as I told you, one of my friends, she also had a cancer breast, and
Mhm,
she was feeding the baby from the other side, and
mhm.
of course, the doctor said that she can have it as a contraceptive method. So, can I have that?
Which contraception? What contraception?
Breastfeeding my baby.
All right. Yeah, breastfeeding. Yes. Do you feel that there is any milk is coming on your breast?
The nurse said that it's the first 24 hours, so after that I can expect.
Mm-hmm. If there is a milk is coming, okay, then you can breastfeed your baby. Yeah,
Well, that's good.
but yeah, but that sometimes it is not 100% guarantee that you will not get pregnant. So that's why
What is
if
what is its effectiveness? You mean what is the chance that I can get pregnant if I'm breastfeeding my baby?
yeah, that means exact figure, it is not my head now. I'll come back after seeing the literature, or I can ask my consultant. I'll
All right.
come to you. Yeah, but there is a not 100% guarantee as effective as coil.
Mm-hmm.
Yeah, okay. And you can, if there is a milk is coming, then you can breastfeed your baby. Yeah, okay. And do you have any other question?
No, so I don't want to have any further procedure. So, if what about the coil? When can you give me this coil? So,
Yeah, this coil, it is suitable for you. Then uh, we can give you appointment for that, or during the hospital before going, we'll arrange for you. Okay,
oh,
and also that we'll refer to your doctor also, the breast doctor. Yeah, if
time is
they'll
over.
give me. Yeah. So I'll give you written information that you can go through, and if you have any question, you can ask me. Thank you.
Thank you. All right, Salma, any reflection?
Yes, that I couldn't finish. I want to say that about the chemotherapy, and also that tamoxifen, if they'll give you, then you have to avoid the pregnancy for 2 years for chemotherapy, and for tamoxifen also 3 months. You have to avoid. It depends what they will give you after operation. Okay.
That was the hidden agenda.
Uh,
That was the hidden agenda. Why the pregnancy should be terminated at 28 weeks. I had a cancer breast. The breast lumpectomy was done. I am planned for further treatment. That's why the cesarean was done when the baby reached viability, right? So I told you that. So immediately you need to ask me, so what treatment are you planned for?
mhm.
So what treatment I'll be planned for? Tamoxifen or trastuzumab. That's the one that
Yeah.
is given. So I'll be planned for a chemotherapy. So with chemotherapy, will you offer LAM, lactation amenorrhea method? Can she breastfeed with tamoxifen and trastuzumab?
No.
That was the hidden agenda. So LAM is not suitable for her. Only method suitable for her is the copper coil. You can also advise regarding the barriers, but the chance of failure you need to explain, right? So that was the hidden agenda behind this station. And one more thing I wanted to tell you, the information gathering took almost 6.5 minutes. So a little bit more fast you need to be on information gathering. I think thrice or 4 times you asked me what medications I am on, what medications and I am on, I'm rightly on. So
Mhm.
please don't repeat questions.
Okay.
That gives an idea that you are not listening properly. Okay, so that gives an indirect evidence
Mhm.
about how you are listening to the role player. Role player also gets annoyed if you keeps on repeating questions.
Mhm. Yeah.
The other very, very important thing, the first question you asked me was, how are you? I said I had a cesarean section and I'm having pain. Immediately you told me congratulations. So please don't make that mistake. Okay. So when I say pain, I'm really sorry. Did the nurse give you the pain relief? Then I say yes, I got the pain relief. Then you congratulate me for if I had a baby or whatever it is. Don't immediately congratulate when I say I'm having pain. Okay. So
Okay.
please listen to the role player what she's saying. It gives a real negative mark. So don't
Okay.
do that. Okay. Then rest of the things, okay, history taking was okay. So how you counsel this patient? What are her options? This patient, her option is, one is a copper coil. When do you insert the copper coil? Within 48 hours after delivery, or at 28 days, or at 4 weeks. So she's
Yes.
only POD 1. So you don't offer her copper T at discharge. So you'll be offering, so there is further 24 hours time again to insert a copper T, but having an LSES, it may be painful for her. So the only other option left with her is at 28 days, at 4 weeks, you can insert. Up to 21 days, if she is not breastfeeding, the chance of having a pregnancy is very low, is rather nil. But after 21 days, between 21 and 28 days, there is definitely a risk if she has a unprotected intercourse, which you have to counsel her. Then tell her, if she asks, what is LAM? You tell her. So LAM is suitable only for women who are exclusively breastfeeding the baby and for whom the periods has not returned and within the first 6 months after delivery. In your case, as you are being planned for further treatment, it could probably be a chemotherapy where breastfeeding is not advised. So lactation amenorrhea is not, or this method of breastfeeding is not a suitable option for you, even though in other women the effectiveness is 95 upon 100. 95% is the effectiveness of LAM. So other women, this may be effective, but in your case, since you're not breastfeeding because of this reason, this may not be a suitable option. Now the other hidden agenda along with this case is, she's a 25-year-old with cancer breast, a young woman with CA breast. What are you worried about?
Yes, she can be
Genetic
pregnant.
problem. Genetic.
Family
Yes.
Can
history.
be.
Family history,
Genetic.
definitely
Family.
she asked. Yes, it could be a BRCA. it could be a BRCA.
BRCA, yeah.
So how do you screen for BRCA? So if you have a definitive family history, yes, it could be due to any reason, any default in the gene. So what you can offer is the BRCA screening. So if I'm having cancer breast, I'll be offered a BRCA screening by the genetic counselor. If I am found positive with BRCA, then a presumptive genetic testing can be offered to other immediate family members, my siblings and children, whatever it may be. So that is the way it goes. Then the chance of detection is more. But if I'm not willing for a BRCA screening, still you can have, if there is a positive family history, yes, the other immediate relatives can be screened, but the chance of having a positive result is less, because even if BRCA turns negative, it could be other reasons as well. That is why you screen the patient who is having cancer breast first with the BRCA, and then if found positive, you offer the presumptive screening for the others. So there is one role that you can offer BRCA screening for her, and you can offer a genetic counseling, and you can also discuss with her regarding the risk reducing surgeries, the lab BSO, which can be offered to her after she completes the family. And of course, as you said, she can have the subsequent pregnancy should be only after 2 years of completing the chemotherapy that you said. So these were the hidden agendas associated with this station. So it's a small station, short station. Only thing is you should identify what are the contraceptive options in such a case. Okay, Salma?
Yeah, thank you. And BRCA, how we can say that faulty gene, we can say that, isn't it, to the patient? Do you
Yeah,
have any
so
faulty gene history?
yes, so there are certain genes in each one of us, and these genes, they control the development of cancer. Sometimes these genes can get faulty, and that will increase the risk of developing a cancer. So there are genes which prevent the occurrence of cancer. Sometimes these genes can get faulty, which will increase the risk of developing a cancer. Such a type of gene is BRCA, which is also a dominant gene. If you have one of these genes, there is 50% chance that you can transmit it to your children, or you could be a carrier as well. All right.
Yeah, thank you very much for
So
nice.
suggestion,
Thank
yeah.
you.
So suggestion, you start with hello, inquire about her recovery. So how is she? Are you okay to talk? So she's an immediate post LSCS patient. Okay, hello, I'm Dr. Vrinda, one of the doctors in the ward today, post-operative ward. May confirm. Or you can ask, are you Gemma Splits? Because she's already admitted there, right? You're supposed to know her name. Are you Gemma Splits? May confirm your age, please. That is enough to confirm her identity. So Gemma, I can see that you had a cesarean yesterday. How are you coping up with? How is your pain? Ask something about her recovery. Did you empty your bladders? Have you seen the baby? Do we have a boy or a girl? Have you named the baby? Ask her something like that. She's already, maybe she was depressed with a cancer breast. Ask her something like that. Ask her about the bleeding. Ask about the baby. Has she go to see the baby? Where the baby is? Did she start breastfeeding? If she has started breastfeeding, is it from one side or both sides? Whether she is encountering any feeding problems, does she have adequate supports? With respect to a breast cancer, can you tell me more about the condition that was discussed? And you have to have lot of empathy, and this is a very, very sensitive situation. So lot of empathy, identify the situation, ask her, can you tell me more about the cancer, or can you tell me more about the condition that you had? What treatment was offered to you? Are you planned for a chemotherapy? And are you advised regarding further follow-up? So this will give you an idea whether she is planned for a chemotherapy. Now, can you tell me more about the delivery? Any other complications? Were you using any contraceptives previously? Any other medications? Any medical history? Allergies? Family history of cancer breast? Very, very important. Addictions? Do you remember your height weight ratio? And in a patient who has recently delivered, rather than asking, have you ever felt down or depressed in the past 3 weeks, you can assess the mental health with, how are you feeling as a new mother? That's a better way. Even in a postpartum mental health station, so mental health evaluation station, you can ask her, how are you feeling as a new mother? Postpartum blues, everywhere you can ask such a question. Can I examine your breast of a chaperone to check your blood pressures and your tummy? That is more than enough. Okay, don't go deeper into such things like, I want to examine your breast, I want to examine your wound, I want to see if you're bleeding. No need. Can I examine you in presence of a chaperone with your consent to check your blood pressures and examine your tummy? Now, then go on to the contraception. With respect to the contraception, as you plan for a chemotherapy, you will be advised not to breastfeed. So if you're those women who are not breastfeeding, contraception is not required till first 21 days. And we cannot advise regarding any hormonal methods too, since you had a cancer breast. And until the periods are regular, natural methods are also not reliable. The other option left with is a copper coil, which is basically a plastic device, a T-shaped device, which can be placed within the womb. This can be placed within 48 hours after delivery, or at 28 days after delivery. Within the immediate 48 hours, there is a problem as you had a cesarean section. The the womb may be, the opening of the womb, or the neck of the womb may be closed, and there may be difficulty in inserting the coil. It usually takes around 5 minutes, and the coil can be placed. Coils may stay there for 3 years, 5 years, and 10 years, depending upon their durability. There are certain complications which can be associated with a coil, like sometimes the coil may be expelled. There is a possibility of infection. There is also a possibility of damage to the womb. In 1 in 100 women, there is a possibility that this can fail. In 99 upon 100 women, this is a safer method, but in 1 in 100, this may fail, and it can lead on to a pregnancy, which can happen within the tube, which may be a life-threatening situation as well. I don't mean to scare you, but it's my duty to give you the right information. So that is one option which is suitable for you. The other option would be the condoms, which are barriers, which can also offer, which can be used, and this will protect against sexually shared infections as well. Now, with respect to another method, especially which is called lactational amenorrhea method, which is possible only for women who are exclusively breastfeeding the baby for the first 6 months and they have no return of periods. In your case, we cannot recommend that. Now, if she is on tamoxifen, there is no breastfeeding and this is not possible, which you have to tell her. And also ensure, it's very, very important that you continue the follow-up with the breast cancer team and continue the medications as advised by them. Now, some medications, sometimes the aftercare may be in the form of x-rays, or sometimes certain medications which may affect the ovaries as well. So there is an option of egg freezing as well, which will be discussed with you prior to starting the medications. And once the treatment is complete, if you plan for further pregnancy, you can have it after 2 years. I would also like to review the reports, because she also had a cancer breast, right? So you want to know what was the histopathology. I would also like to review your reports with your permission. And I would like to also tell you that there are certain genes which are associated with breast cancer called the BRCA, which are dominant genes and which can run in families. So we will also put you in touch with the genetic counselor. He will offer you a screening and also discuss with you regarding the risk reducing surgeries, which can reduce the chance of developing cancer of the ovaries if the BRCA is found positive. Any other questions? So check her understanding in between, offer her leaflets, document this, appointment with the consultant, and then close the station. Any questions? Selma?
No, thank you very much.
Any other questions? Anyone?
Dr.
Yes,
Can I ask?
Yes.
Because it's not on treatment. Physician, they ask when they have a plan.
Adya, it's not clear.
It's not Athena, it's I think Dr. Usha.
Dr. Usha, it's not clear.
I have to ask. Okay, I can ask. Okay, when your doctor is going to have a give you medicine for anti-cancer.
Yes, usually
Yeah.
it will be, yeah. So usually they
Yeah.
start. So that is why, yeah, you can definitely ask. That's why the
So,
cesarean has been planned at viability. Yeah, they will be
yeah.
starting
So,
immediately. Within 3 to 4 weeks, they'll be starting.
yeah, so we can ask like till if they are not starting now or maybe 4 weeks later, till that she can breastfeed and so she will be protected like 4 weeks, and after 28 days she will have a property.
See, majority of the times it will be started as early as possible. So if the cesarean was done at term, maybe it's not that urgent to start a chemotherapy. Why it was terminated 28 weeks means there is an urgency to start a chemotherapy. Okay, maybe 2-3 weeks they will give the time and they will start. So
Okay.
if the cesarean section was done at term, definitely you can ask. So when is it planned? Is there a delay? Then you can definitely advise regarding lab. Depends
Okay.
on the station.
Mm-hmm. So in her like a 1 week window, so she can have a, I mean, she can't have any barrier contraception as well.
Also, you need to, yeah.
Suppose.
Also, you need to ask her. So if a lumpectomy was done, what was, if in such a case, if you plan to
Mm,
breastfeed her, maybe it is done at 37 weeks and the chemotherapy is delayed, you need to ask her at what part of the breast was the lesion present. Was the lumpectomy done along with the removal of the nipple? Was it present on bilateral? Right? So if the
mhm.
nipples are also removed, then of course it may be difficult. So it depends upon the
Mm,
location of the tumor as well.
okay. Mm,
Can I ask
okay.
now?
Hello, I have one doubt, doctor.
Yes.
Hello.
Yes, yes,
Yes, doctor. But she's in 1 day post-op, so if she agrees, we can put even now the copper T, right?
yes. Within 48
Yeah,
hours you
but
can.
yeah,
But
because
you have to
if it is not
be
put
painful.
postpartum cesarean,
Yeah.
postpartum IUCD, if not put, we can put even now before if she decides
Yeah,
before.
postpartum, immediate postpartum is within 48 hours. That's why you tell her this can be placed within 48 hours, but there is a possibility the neck of the womb may be closed because she had a cesarean. It may be painful. That you have to counsel her.
Only things.
Yeah.
Okay. Okay. Thank you.
Doctor, can I ask now?
Yes.
If there is the same scenario, but she had lumpectomy, and she said her doctor, her onco doctor said that she don't need any further treatment now, and she delivered at term. Then she can breastfeed.
Yes. She can breastfeed from the other breast. She's not having any chemotherapy. She can breastfeed from the other breast. You can offer her lamb. You can offer her copper coin. No
Why
progesterone.
from? Hello.
Hello? Yeah.
If her nipple is intact from the second breast, from the disease, she
The
can
other breast
breastfeed
she
from.
can. The other breast she can. Not from the deceased breast. The other breast she can.
Why?
She's not on chemotherapy. Why she can't breastfeed from the other breast?
No, no, she can breastfeed from other breast, but why she can't breastfeed from diseased breast? If
It
she
depends
had,
upon the location. That's why I said where it is. Depends upon
if
where the lump was located. If it is
if
involving the nipple, there's a lot of disturbance in your call. Okay, so if it is located on the nipple and the nipple is removed, she may not be. Then she can
okay,
feed from the other breast.
nipple is spared, and she had some outer quadrant lumpectomy, then she
Yeah,
can breastfeed from same
sure,
breast as well.
sure.
Okay, thank you, thank you.
Any other questions?
If
Excuse me.
she, hello.
Hello?
Yes, if she is BRCA positive and
Yeah.
she had now a female child, will we say to her that she needs to screen her child too
Yes,
now?
all her, not now, not immediately. But you have to tell
Okay,
her yeah, the genetic counseling will be offered to her siblings and all her female children.
okay,
Even
thank
the
you,
male
thank you.
child, there is a risk of BRCA positive, there is a risk of prostatic cancer, male breast cancer.
Cancer,
Yeah.
great. Okay, thank you, thank you.
Excuse me.
Yes.
That for surgery we can do any stage of pregnancy. We can do the surgery for the breast cancer,
Yeah,
and
surgery can be
radiotherapy.
done.
Radiotherapy
Reconstruction is not
we
done.
can, yeah, radiotherapy we cannot do,
No.
and chemotherapy we can start from after second trimester. Yeah.
Tamoxifen and trastuzumab, you won't
No,
give, right?
chemotherapy,
Yeah.
other chemotherapy. We can
Yes.
start second trimester, but
Yes.
tamoxifen and that trastuzumab we cannot
Yes.
give in pregnancy. Yeah,
Yes.
thank you.
Any other questions?
When we'll do the reconstructive surgery? Reconstructive surgery we cannot do during
You cannot
pregnancy.
do
We
in
can do.
pregnancy.
We can go after the delivery. We can do. Yeah.
Maybe. I'm not quite
Yeah.
sure about that.
Yes.
When
Yes.
the reconstruction is done.
Yes. Thank you.
All right. Any other questions? So we have discussed 3 stations: peripartum cardiomyopathy, negotiation, and postpartum contraception. So that's all for today. 3 stations. Thank you all for your patient listening. Please give feedback in the group. Thank you so much.
Thank you very
It
much.
was wonderful
Nice.
presentation, doctor. Thank you.